I think it's really important to start with creating that apex of the cheek, whether it's a male or a female. So figure out where that is and really support that first, because that's where they're going to get the most lift. And then I like to blend a little bit lateral and then I go medial and definitely build that anterior projection in the mid face to support the under eye. If your patient's on a budget, that's what you start with. Apex of the cheek, blend lateral, blend medial, stop there. Then if you can, I start doing a little bit of the periorbital support. Majority of the product is typically needed mid-pupillary. That's kind of where I find most of the deformity is, based on just bone and fat loss. So I always inject on bone everywhere except for in the mid face. You're in the deep medial cheek fat. Otherwise, you're all on bone. And then I just fill mid-pupillary doing tiny little micro struts of product. You don't want to do too much in one area for lymphatics or migration and safety. And then I will go into the tear trough if needed. And I actually try to place product in the tear trough ligament itself, which is tricky. But if you can get your product within the deep confines of the ligament itself, you are supporting the ligament and it lasts a long time. If you err on either side, in the true tear trough, that muscle is actually interdigitated to the bone. So you are injecting in a muscle on either side of the ligament, which is okay if you're placing tiny, tiny bits of product. But over time, we all know what happens when you put product in a muscle, right? It can extend superior and end up creating like a little worm of product. So you have to be very careful about the amount. We go over all of that in our training, and I show injectors how to get into the actual tear trough ligament itself. I always use a cannula. And then from there, I always blend lateral and really help with that orbital malar groove, that palpebral malar step off that a lot of people have because of how tight that ORL is. And actually, we know the orbital retaining ligament bifurcates and splits, and you have a small little gap between there. So I show injectors how to get in between there and actually do tiny micro struts to really help blend the lateral orbit. So you don't have a step off, because how many times have you had patients come in, their mid-face cheeks look on point, their tear troughs have been filled, but they have this like crazy, terrible step off laterally in their orbit. And you're like, well, their injector didn't know how to handle that. Because it's tricky. I mean, the anatomy is tricky. So I make sure I show, injectors how to blend that and then finish kind of softening and blending into the temple. So that's kind of the approach, girl.